And now what we're going to do is we're going to change it more from the medical to the sort of nuclear medicine / other types of treatment discussion. So I was getting worried I couldn't see my team around, but then Muriel's sitting there and Richard Baum's Richard? Oh, he's coming. And then Walter Kocha, my colleague from London, is going to come up and pretend he's the other four. Because there's one or two questions that are sort of, they're not quite straightforward, and we want to try and deal with them. So if you give us a couple of minutes to get the people up on the table here, we will see what we can do. Okay. Now this question here was one which we weren't quite sure how to answer this one, because there's not many people have had liver transplants. But the question is, after a successful liver transplant, what is the likelihood of a recurrence of tumours in the transplanted liver? Well, we've had 2 patients that we've transplanted in London, and so far they're fine. However, let's ask the panel what they think. Muriel has is from London and from King's College, and they have a liver transplant program, right, Muriel? So the question
yes, in fact, how I got into my interest in neuroendocrine tumours was in 1994, when we used our first octreotide scan agent on a patient who had had a liver transplant. Our hospital is a major centre for liver transplantation and all forms of liver surgery and treatment. And we had a huge database of patients who had liver metastases, which was the way they came to us, and then was subsequently found on the biopsy to have neuroendocrine tumour. And it was from this this first octreotide scan, that we started to develop a carcinoid clinic, and I showed you yesterday the team. But it started with this octreotide scan on a liver transplant patient, and the remarkable thing about the scan was that the patient had metastases nearly everywhere except the liver. And this was quite interesting. I have my views about transplantation and whether the organ that the donor gives keeps its personality, if you like, when it's put into the recipient, but that's another story. The important thing was that at the time we had no other means of determining the staging of this patient's neuroendocrine tumour, so they could well have had all those metastases before they had the transplant. On the other hand, we then did do 1 or 2 others, and we felt very strongly that we should stop doing transplantation because of the anti-rejection therapy that the patient receives, which seems to stimulate metastases. We've had 1 patient more recently whose whole liver is full of neuroendocrine tumour. I've given him MIBG therapy on several occasions, and he was offered a transplant because we could not detect any extra liver problems. And he was, however, not suitable for a live-related donor transplant. And then he was offered another sort of substandard, if you like, liver, which they thought he would die within a year and that the transplant would at least last 5 years. The patient refused, and we're now talking 10 years later. He didn't have a transplant, and he has now got spread outside his liver, but he's there. So I feel in general terms, even if you know your disease is confined to the liver, you can't be certain. And by having a transplant, you may provoke spread because your immune system is down, because you're trying to prevent the rejection of the liver.
Richard?
Very short answer. We have 800 patients studied with PET-CT. Among them were 9 after liver transplantation due to a carcinoid tumor. Of the 9, 7 had no recurrence in the liver but outside the liver, mostly lymph node and bone metastases. So it seems to be relatively rare that the transplanted liver is involved, but it is not impossible. 2 cases are positive. And I would strictly recommend, if transplantation is considered in any of these patients, you must do today a receptor PET-CT. It's a must. It's not an option, it's a must, because the sensitivity is so much higher. We have about 20 patients studied which were planned for liver transplantation. And in 18 of them, in 18 out of 20, we detected liver lesions, not liver-related lesions outside the liver, which were not previously known.
Yeah. You see, what one would normally do in these situations is, if a patient had widespread, for example, liver metastasis, you really wouldn't necessarily want to transplant that patient, mainly because there's a higher risk, as Richard says, of lesions elsewhere. And you don't want to put somebody through the trauma of a liver transplant, which is not exactly a benign condition or procedure, and then 6 months later it comes back elsewhere, and you have to treat them for that. I've seen a case like that a number of years ago. The tumour came back 6 months later in the lung. You know, it just doesn't work. So the rare transplants that are done are in people who've been perhaps 3 years without any evidence of other recurrence elsewhere, because as soon as you got recurrence elsewhere, you ain't a transplant candidate. So most people would say 3 years, but you can't. There's not that many people who have actually had transplants, so who knows?
One additional comment, if you allow.
Yes, certainly.
Of course, liver transplantation is done under the intention to cure the disease. Okay, but there might be indications where not cure is the last aim. We have seen very young patients, 15, 16, 17 years old, with traumatic involvement of the liver and a very short, time to live. And in these patients, one can consider liver transplantation, even if there is small volume disease, let's say in lymph nodes or so outside the liver, because they gain probably several years of life, and at this time, of age, I think it's really considering. But it's not established up to now, and something one also have to mention is that in Germany we perform so-called family transplantation or relative transplantation. I don't know the wording for that exactly. Related donor. And of course this is again a different situation. And not always the cure of the disease should be the last aim.
I got another question here, which is is right down Richard's street here. It's a patient has 5-HIA is 2 to 300. Patients get carcinoid syndrome. I take that from what's been said, and they've got abdominal pain, basically continuous. CT, MRI, ultrasound, ultrasound scan are all negative. Should they have a MIBG scan? And if an MIBG scan is negative, is a PET scan indicated? And I think I know what Richard's answer is going to be here, but it's Richard's time to answer another question.
I would not perform a gallium receptor PET-CT in this case, but I would recommend a DOPA, F-DOPA PET-CT. There are some very highly differentiated neuroendocrine mid-gut tumors positive on DOPA and not expressing a significant amount of somatostatin receptors. Of course, MIBG is another option and should be done. But the DOPA PET or the 5-HTP PET, which is rarely available, that's the recommendations.
Yeah. Well, we don't have, in Ontario, we don't exactly have availability of PET in these situations, so it's difficult. The one thing is, normally with carcinoids, we do both an octreotide scan and an MIBG scan routinely. You do get the odd patient who's negative on octreotide, positive on MIBG, so we would do that normally. I guess that answers the question. Now then, it's obviously Dr. Liu. I wish he would have stayed, but he couldn't, about the embolizations. I guess I'm stuck with it. And the first one is actually quite a simple question. He said, Dr. Liu indicated that the nuclear-loaded microspheres are as effective as Lepidol 131 chemoembolization. Am I correct in interpreting that from his discussion? Are there any centres in Canada where the microspheres are being used, and how can they be loaded with yttrium-90 in Canada? Well, that's a kind of interesting, it's a good question. Now, go back historically. 20 years ago, I helped Nordion help develop the yttrium-90 microspheres. I did 15 patients with them. And for the past 11 years, we have used the I-131 Lepidol. And in London, we're using it in combination with cisplatin and adriamycin. Now, Irena Rachinsky, my colleague yesterday, gave her talk, and let me put it in perspective. The microspheres are not really available in Canada. There's only two places that are doing it. Was Montreal, who are doing a clinical trial, and out west, I think Edmonton was doing it, and Dr. Yu's come up from the States he's actually Canadian, was trained in Montreal, went down to the States and has come up to Vancouver, and he's going to be starting to do some work in it, but there'll probably be trials as well. The I-131 Lepidol costs $2,500, and we can do at the same time 2 livers, half a liver. Normally when you're doing an embolization, you don't do the whole liver, you do half a liver. You don't want to cause too much toxicity to a whole liver, because that's not exactly ideal for the patient. So microspheres in the US cost $15,000, $16,000, give or take, depending on the exchange rate. I-131 Lepidol is $2,500. So if you look at it, there's effective as equally effective. Then what's the take on it? I've done both. I don't think there's much difference between the two. There are some technical issues. The microspheres with the Nordion version, the Theraspheres, you cannot fractionate the dose. So if you go in, you have to do an angiogram before, look at the anatomy, and then order your dose. Liver's anatomy is notoriously variable. You can have numerous different patterns. The biggest problem you have is you've got to get away from the vessels to the gut and the stomach. Because if you put yttrium-90 microspheres down them, you'll slough the bowel and the stomach lining. And that ain't a good idea. And I have to admit that I had 3 patients of the 15 that we had years ago. The catheters weren't as good, the technology wasn't as good, and we had 3 people who got that complication, and it was not pleasant.
Well, we've been doing this now in neuroendocrine tumor patients. Actually, in the UK, this is recommended for patients with colon cancer and liver metastases. It's actually licensed for that. But they're looking at extending the license to neuroendocrine tumors as well. The most important thing, actually, you've just alluded to, is that we do what is known as a shunt detection test first, which is you inject just your normal microspheres that you use for diagnosing pulmonary emboli into the hepatic artery during an angiogram, and then you're able to assess whether or not there is a shunt going to the lungs. And if there's a certain percentage, and you're given quite strict criteria, you cannot proceed. So you have to do that test first before you can go on to the microspheres. This is yttrium microspheres. They're so-called SIR spheres. The actual technique itself is quite complicated, and they have a special device for delivering the labeled microspheres into the liver. You can do one side and then the other side, that is, I mean the right lobe and then the left lobe, or you can do both. Everything depends on the angiogram and the assessment of the volume of normal liver left. And actually, I don't know if there are any radiologists in the audience, they're not very good at assessing that. And this is quite an important area, because we had a patient with an insulinoma whom was said to have well over 50% of their liver functioning, and that the liver function tests were quite normal, But actually, the patient had diffuse, as you know, with the insulinomas, the liver lesions can be tiny. And actually nearly all, there was no bit of liver that didn't have a little bit of tumor in it, even though the liver function was normal. And the radiologists assessed that there was more than 50% liver function. And actually this case was quite unsuitable for the reasons I've just said. So with the neuroendocrine tumors, I think it's very important to accurately assess the functionality. And we actually do the appropriate imaging with the shunt we do SPECT. I don't know what you would do, to actually assess where are these microspheres going before you use the labeled microspheres. And we also, after we've done the procedure, we image again using Bremsstrahlung radiation, because one of the things the surgeons are always saying is, yes, but where have they gone? We can't tell where the yttrium microspheres are. Well, we can. By using nuclear medicine special techniques, you can actually identify whether we did hit the spot and it did go to where we thought it would go. Yeah. So it's sort of early days, but actually we've done a number now, and we're now looking at liver tumors in general, so we are able to do it. But for neuroendocrine tumors, I do warn you about particularly the insulinomas, that you can get diffuse liver involvement that makes the liver look perfectly normal, but in fact is studded with tiny tumor.
Yeah.
Okay, if you allow me first to answer your question, what we do for shunting. We do the same like new up to now, but believe it or not, we will do it with gallium-68.
Oh, I'm sure you will.
No, I have 3 weeks ago, I have done the first study in the world on myself using gallium-68 labeled microspheres.
And he's still alive.
Because I think it's so important.
Yes, it is.
Okay, so shunt is a very important issue. The second issue, the liver function. I completely agree again with your comments. And what we do is we're using technetium colloid scans and hepatobiliary scans, where you can really measure again the liver function very accurately. It's a very simple test, just takes 20 minutes, and you have the answer. Concerning the embolization, one have to differentiate between the yttrium-90 spheres, the Thera spheres from Nordion, which are commercially available, nearly the same price. Thera spheres are a little bit more cost effective in Germany, but still very expensive, between 10 and 15,000 euro per treatment. And then you of course have something which the International Atomic Energy Agency did, the rhenium-188 labeled lipiodol. Yeah. And if you have such a generator, a rhenium-188 generator, the cost comes down to $150. Right? As compared to 15,000 euros. So you can fly to Vietnam, you can fly to Cambodia, to Singapore. Yeah. It's done everywhere in the world with rhenium-188 lipiodol, and the results are very good.
Well, that's exactly it. We have 5 years tried to get it, but there's technical, I mean, Ian up in Ottawa said, yeah, sure, I'll give you the, the letter. But we have a problem with the labeling. You know, the kit for the labeling.
There's a new kit available. I can give
that's
you
right. There is a new kit. And the gallium generator is about $60,000 or $70,000, and you can do lots of things with it. It's effective. I think it's good for about 6 months.
Nearly a year.
What for the generator? It's about 6 months to a year.
The rhenium?
Yes.
Oh, the rhenium.
The rhenium, I think you have to change it every 2 or 3 months, depending upon.
But if you look at the actual, if you compare it to the cost of the microspheres, you can do 4 microsphere patients to a generator that you can do lots of patients with. So you see, there's a lot of the microspheres, you might say, are sexy, but there's other options that are cheaper.
So these generators are really interesting.
Yeah.
For example, rhenium-188 you can also use for bone metastasis treatment.
That's
if
right.
You fix it to a biphosphonate, again you can get down the price by a factor of 10 or so as compared to what is commercially used.
But what the biggest problem is for the Americans, it's the FDA. For the Canadians, it's our government people. You heard him yesterday. He'll help out as best he can. We have to do it. The problem is at the moment with the rhenium generator was the labeling. it's possible to do it, but the kit wasn't available. So I think the Korean kit wasn't quite a good kit, if I remember rightly, and the activity leached off when you had some toxicity issues. It's possible, but if you look at it on basis, the way we're doing it in London, we can, it's $2,500, 2 patients. It's very reasonable. You have to keep the patients in for 5 days to give them antibiotics, but it works. So basically, at the moment, we're the only place in Canada that does the yttrium 90, not the yttrium 90, the Lipidol, and we can get it without too much trouble. It's just that we can only do 4 patients a month. We've got the hospital budget is such that that's what we can angio time. The other thing is we do not have to do a pre-angio. We don't, because the shunt with the Lipidol is not quite as critical. We've had several people who've gone 20% shunts that we've calculated after we've done it. We had one person with 40, not a problem. If you'd been that level with yttrium 90, I think it's over.
Well, we wouldn't have done it.
No, we wouldn't have done it. And in fact, is it 5% the shunt?
It's 10.
10. If you get a 10% shunt, you're not going to get the microspheres, whereas a lot of patients are above the 10%, 10-20%. So again, I think that explains why we prefer to use the cheap one, that actually you've got a better range of patients that you can do.
Can I just make one other small point,
Sure.
which you alluded to? You do have to keep the patients in with the I-131 Lipidol. With the yttrium 90, you might need an overnight stay, but sometimes they can just go home.
Yeah,
after
that's another issue.
There's no awful feeling after the embolization using the yttrium 90.
Because sometimes with the I-131, some patients feel real punky, other people feel great, and the next time they get it done, the ones that feel great, they feel punky, and the other ones that felt lousy, they're fine. Hey, take a coin, toss it, you're staying for 5 days, no matter which way you look at it. The next question here is for Richard. Again, gallium-68 PET-CT. If it was available, would you suggest an overlap period when both the octreotide scan and gallium are performed, or just go directly to gallium-68?
The answer is very simple. The last 4 years we have not used octreoscan anymore in our department. It's like comparing a Volkswagen with a Ferrari. And if you are used to a Ferrari, you don't want to drive a Volkswagen anymore.
Yeah, but
so, if it is available, we only do receptor PET-CT.
Yeah.
If it's not available, of course, octreoscan is still a good method. It's better than nothing, and it's better than many CT scans, MRI, and so on, because it's a whole body method. So it has still its value. But if the receptor PET-CT is available, I always would do a receptor PET-CT.
Yeah. That's what most of us would say, but we have to fight with what we got. It's very difficult.
I don't think you should decry octreoscan. It was the leader.
There's nothing wrong.
There's nothing wrong there. Patients are going to have
Yeah.
octreoscan as their screening agent until we all aspire to the Ferrari, but actually a VW is a perfectly good car.
Yeah, the BW is a... the octreoscan is a Volkswagen, okay? The BW is a technetium-labeled compound, which is available in Europe as tectreotide, which is a technetium-labeled octreotate, actually, which comes from Poland and is licensed in Europe. And it's very good. With SPECT, and especially with SPECT-CT you showed yesterday, there are very good results, example from Warsaw, from Poland, and so on. And we also have used it in several hundred patients before we had the Ferrari. We did the technetium-labeled octreotide. And it's very good. And you can also get your results within 1 day.
That's right.
So you have a 1 hour and a 4 hour scan, and you can go home. It's not like the octreoscan where you have to do 24 or 48 hours.
Yeah. Ian Mackay's comment about me phoning them, that's been going on for the past 6 weeks, doing some cajoling. What about this? What about that? And they're sort of pretty reasonable. Our biggest problem is there's a couple of little logistical issues about labelling and things like that we have to personally arrange. But maybe sometime mid-next year we might be able to do some tech-labelled scans. Again, there's one advantage. How much did it cost?
The technetium-labeled agent is much cheaper than the octreoscan. It's around 500.
Per patient or per kit?
per kit, so you can do probably 2 or 3 patients out of that.
So here,
whereas with the Octoscan it costs in Europe 740 euros, and this is per patient because you cannot dilute it.
Yeah.
But I mean, to make a long story short, for all the patients, because you might now get confused, there is technetium, indium, gallium, water 2 and so on. I think you should do what is available in your country.
Yeah, exactly.
That's the most important, and you should do the best which is available in your country. So if you are in a country where there is only Octoscan available, do the Octoscan, because it's the best which is available. If you are in an environment where you have technetium available, you can do technetium, and if gallium is available, you should go straight to gallium. That's my recommendation.
And also the technique of how you do the scans is very important. And planar, by that I mean just two-dimensional imaging with Octoscan, or with anything, MIBG, it's now not acceptable. And we, in the nuclear medicine profession, should be doing volume imaging, three-dimensional, with or without the CT component. And you can always fuse anyway.
Yeah.
I agree completely, except that the SPECT, you not do whole body SPECT, right? You usually do one region. Yeah. But it's not done.
Anyway, we got another question here.
I do.
They've had a liver section, gallbladder's been removed, small bowel resection. Does this mean I'm not a candidate for therapy such as microspheres? Well, it depends on your anatomy. When the surgeons have been in there and chopping things out, you don't know what vessels they've tied off. Frequently the vessels, they've developed collaterals, and you really have to do a good reconnaissance before you decide what you're doing. One of the interesting things we've just found out in the past couple of months where we are, they've now got CT angio, where you can actually, the scanning head goes around the patient while they're injecting the actual contrast when you're on the table doing the embolization, and you can actually pick up the vessels and get a better look at the vessels. And that's what we've been doing for lipidols. So it gives you a chance to really assess it. We've had people who've been resected like this, we've been able to do them, and then there's a very small number. When you go in, you suddenly find out that maybe you can do one side of the liver, but you find out there are collaterals to the other side, and you can't do one side. So it's really, you have to really assess it very carefully and make your decision what the best treatment is for the patient. I mean, sometimes the surgeons can go in and RFA them, do wedge resections and do all sorts of things if there's enough liver that you can do. And the point about it is if there's enough liver there that you can safely actually do the therapy. Because if the liver has a very small volume liver, it makes life very difficult for either the yttrium-90 or the lipidol.
I think it also bears pointing out that there's a number of features that can occur that would make you ineligible to have hepatic arterial therapy. That may have been covered in a previous talk, but if you've had a Whipple's procedure with a replumbing of the biliary tract system, you can't do this because there's a very high incidence of hepatic abscess. And if you have a stent in the bile duct to keep it open because of pressure, it's the same consideration. And we've even had the experience of finding people's bile ducts enlarged in the liver, even though we can't find a reason for it. It's not blocked. And yet those patients also get a higher incidence of abscesses. So we now exclude those patients because the risk is much too high for that occurring. And there's a whole number of other factors, including the portal system has to not be blocked, and there must be less than a certain amount of liver involved, and the liver function has to be up to a certain level. One of the things that really inhibits us from doing some of the patients with lipidol is the fact that the kidneys aren't working well enough, and you really can't give the contrast material safely for the sake of the kidneys. There's a number of other factors that come into play.
Just to mention, cholecystectomy is good. I mean, if you had cholecystectomy, it's an advantage before embolization therapy, because very rarely it happens that you embolize the gallbladder. We just had a case 2 weeks ago where some of the microspheres were going to the gallbladder. So it was not shown before on the perfusion scan and not on the angio that it can happen. But cholecystectomy is good.
Yeah. There are several questions that we're into this point about technical aspects of it, who's available, who's not available to do it. And this question here is, when's it time to get it? Embolization. What if you don't have heavy liver metastasis but do have a large residual mass when you've had previous surgery and you've got recurrence of a mass and it's, I can't read the writing here, but I think it's mesenteric encasement. In that situation, now normally speaking, if you've got disease outside the liver, most of us would not do an embolization because you're not going to cover the other disease. And the other, even though you treat the liver, the other disease is going to progress. So I don't know what Muriel and Richard think about it, but that's, I would be...
It's individual again.
Yeah.
It depends the sequence of events.
Yeah.
The criteria for the embolization are firm and fixed, and you've heard a whole load of exclusions. So if any of those things are present, then you wouldn't. But there's nothing to stop doing combination things.
Exactly.
You can do the spheres and then go on to do a radionuclide therapy for the other lesions or whatever. The fact is that dealing with the liver is such a good procedure because you debulk usually quite a lot of tumor. And it's a very nice way for the patient to know that tumor has gone.
Yeah.
With the radionuclide therapies, you hope to affect the mitoses of the tumor, but you may still see the tumor there.
Yeah.
But of course, the activity may be less. So all of these things, we've got patients who've had RFA, spheres, radionuclide therapy, whatever is available at the time you're looking at the patient. You have to take all that into consideration. Yeah. And usually, one thing doesn't stop you doing another.
But one thing here is that there's involvement elsewhere in the pelvis and the abdomen.
Yeah, I completely agree what Muriel said. Yeah. It's really a multidisciplinary effort always, and it depends what you have available, right? I mean, if there is involvement of the bowel or pelvis or whatsoever, which causes obstruction, then the surgeon is the one I would ask to solve this problem. If there is no obstruction, you can go on with peptide receptor radiotherapy. In many cases, peritoneal carcinosis or mesenteric involvement responds very nicely to lutetium or to Y90 DODA-TOC or DODA-TATE therapy. And if there is massive involvement of the liver, this is something you should really attack first. Because to say it clearly, the liver decides how long the patient lives.
Yeah.
You can have bone metastases and live 10 years without problems, or lymph nodes or so, but the liver is really the decisive organs for the prognosis of the patient. And if there is a big mass in the liver, I completely agree with you, one should really think what to do first, to do chemoembolization or SEERS or the surgeon. I mean, if you have, you can do hemihepatectomy, you can do trisectomy of the liver, and so on. So it's really a combination. Yeah. But if there is disease outside the liver, one should always consider peptide radiotherapy.
If you've got disease outside the liver and the liver disease, would one, for example, with your lutetium or the yttrium-90 octreottate, or MIBG, would there be something to be said for doing that because you can cover all the volume of disease in one go? Or do a stage?
It depends. I mean, if the liver is not, let's say, a problem concerning the amount of involvement, we always start with peptide receptor radiotherapy and then go on. I mean, many patients then have for years, they have peptide receptor radiotherapy. So the time between circles or courses become longer and longer. We have now patients with 2 years in between courses of radiopeptide therapy. As long the patient is stable, is doing well, we should not treat an image, right? We should not treat a case, but we should treat the patient and the symptoms from the patient. And as long there is no progression, there is no reason to do a therapy which can affect organs like the kidney, the bone marrow, and so on. I think this is a very important point.
Good.
I would, I'd like to second that as well. We certainly see a group of patients who are in the older patient group, 70s. They have low volume disease in the liver. They're on somatostatin, and the disease seems stable. And I think a good proportion of those patients can live out their lives without ever having to need to have that treated, and will likely succumb to some other problem before they ever run into a problem with their disease. So there needs to be a degree of judgment in terms of whether the disease is progressing, how threatening it is, and clearly there's a group of patients that have very stable disease that's not bothering them, and they may in fact never ever need therapy.
I'm trying to get, we've got several questions here that sort of are a little bit of this and a little bit of that. And basically they boil down to what are the contraindications to the treatment. And I think basically we've discussed this quite well. There's one thing that has to be said, and it's been alluded to, is that you've got to, the point about the patient is you've got to be looking at the whole patient. And the decision to do any therapy is based on the patient's clinical condition at the time. So if you've got a patient, for example, who's got an ongoing infection for whatever reason, the patient is very debilitated, those situations often will put them into a sort of performance status below which the patient really would not be a candidate for, any of the treatments. So the first part is that you've got to look at the patient's overall clinical condition. Some people, unfortunately, are just too far down the road, and you just can't treat them because the disease is so rapidly progressive. Any treatment you've got may not be able to arrest the condition. We have to give, for example, the peptides, any of the peptides, it's not just one treatment that is the thing, it's the whole course. I think everybody would agree to that. You've got to get the full course of treatment to get the full benefit. So if the patient's condition is going down very rapidly, their actual clinical condition may outrun the ability to actually treat it. And that's one of the considerations. Somebody had asked about multiple liver tumours, not a viable option, and the treatment options that are available. Well, you basically got to look at the whole clinical situation and pick the best one. And it may be the surgeon do something, the nuclear medicine people do something, the oncologists do something, and it's a whole mismatch. We've had people who've had liver surgery, an embolization with I-131 Lipiodol. Then the surgeons have been back again because we've shrunk the tumours in such a way that we can actually do a lobectomy or whatever. And you get into a situation where some of the patients have had, for example, 6 embolizations. They've had radioactive isotopes, and the surgeons have actually been in as well. So you can't say no to one particular one. You've got to look at the whole picture. So there's multiple options. But the point about it is you've got to have been in a centre that's a multidisciplinary centre where you've got a bunch of people who are all working together. Because if you go to one place that does one thing in isolation, they may say do this, or nothing else is good. You go to another place and they'll say no, we're the best. The best way is to get to a place like, for example, Dr. Woltering's place for the US, and there's several places where everybody works together as a complementary group, and you can put the best deal together for the patient. And that's the word from this, is get to a place that has experience, multiple people involved, and it's the same with Martin Kaplan's group in Britain, and even in Germany, you've got to be to a place where you get all the people who can do part of the job together as a team effort. I think everybody would agree with that.
Absolutely, yeah.
Yeah, I mean, there's Muriel in London.
I'm glad you mentioned me.
Of course I would always mention you. But yeah, you look after our patients that we can do things on. So, and it's the same, Martin Kaplan's group, Richard's here as well. We all know each other, and we know the best person to do the job. It's all a friendly club. We all know what we all do, and we do our best for our patients. Now, this is an interesting little question here. How can a CT scan differentiate between an active tumour and a radioablated tumour. Well, the point about it is the CT scan may not be able to do it because of scarring. That's one of the problems. But this is up Richard Street here. This is Richard's answer
You
here.
answered it already. The CT scan cannot do it. Of course,
Exactly.
if you have a liquid necrosis, it's a sign of a complete, ablation of the tumor or so. But we have seen so many patients with, residual tumor at the rim of the radiofrequency ablation or chemoembolization or recurrence elsewhere. So we really have to rely on molecular imaging or metabolic imaging methods like FDG PET-CT or neuroendocrine tumors receptor PET-CT or other tracers, even indium octo scan, SPECT and so on, might be able to differentiate better than CT scans. So purely anatomic or structural methods are not able to give you this answer. One must say that there are MRI techniques now available which can differentiate between necrotic tumor masses and probably viable tumor masses. There are some recent publications with specific techniques on MRI. So if there is no PET available, or if there is no octoscan available, or if it is a tumor which has no receptors, you should ask for an MRI and go to an MRI specialist doing these special sequences. They all have funny names. You need not to remember that, like flush sequences and wrist and fist and all these things. But there are techniques in MRI which allow to differentiate between necrotic, liquid tumor masses and solid tumor masses still.
In general, sorry, I was just going to say, in general, the nuclear medicine test, whatever, is going to be more sensitive in determining tumor activity. That's, if you like, would be my take-home message. Because it's very difficult to assess response, as you've been hearing throughout the several days. And we're still stuck with morphological change, that is size change, as a symptom of, or the measurement of success, whereas we should now be thinking more in disease activity as the measurement. And if we want to image disease activity, it's usually by a nuclear medicine technique. I think you will agree with me there. Yeah.
I think we, clinically, we've had a lot of problems of being fooled by the imaging, because the classical criteria, which I have indicated in my talk on chemotherapy, is looking at changes in the size of the tumor. But in the liver, this doesn't often work out very well, because the central area becomes necrotic, and it looks like it's larger. The other place where we've been fooled a lot is we have people from various other places sent to us for therapy. And for instance, we'll do an hepatic arterial therapy or a series of isotope therapies. And the referring physicians will get an interim CT scan, and they say the disease is progressing, it's getting larger. But when we look at it, we see that there's now an area of necrosis. There may be some areas that we might construe as being a viable tumor, but above and beyond that, there's an area of edema around the tumor where there's been tumor breakdown, and that's interpreted as being part of the tumor, but it isn't. It's just the reaction of the normal liver to the breakdown products of the tumor, and it makes it look like the tumor is actually larger and progressing. And that's one of the reasons why we wait at least 3 months after therapy for those reactions to settle down, to try to make a more accurate assessment of what's happening in the tumor, at least by those conventional techniques. In Ontario, we have also limitations in MRI, and the major places where the radiologist will allow us to use an MRI, because if you want to get a regular MRI, it's about a year's waiting time right now. But if the other places where we can get an MRI is the increasing problem of fatty liver infiltration in the liver, and the fact that this can obscure disease, especially on the CT scan, whereas the MRI can pick it out. So we have to rely on the radiologist's discretion of looking at the CT scan and will say, I don't think I can tell in this particular one, you really need an MRI here. And if they say recommend an MRI, then we can usually get it pretty quickly.
That's good. I have the last question. and it's a kind of an interesting little question. What percentage of pancreatic non-functioning neuroendocrine patients die from disease-related symptoms?
What do you mean with disease-related symptoms?
That's what the question was.
Non-functioning?
Non-functioning.
I mean, you usually die due to metastatic load, right?
Yes.
Mostly in the liver. And, I mean, of course you get symptoms at the end. When the liver is enlarging, you have hepatomegaly and so on. So there are also symptoms. If it is a non-functional tumor, the patient does not die of his, hormone which is secreted, which still can sometimes happen in metastatic insulinoma. At least we have lost one patient due to hypoglycemia with very heavily metastasized malignant insulinoma. But I think at the end you will always have symptoms.
Yeah.
Yeah, maybe the simple answer to that one is if you have symptoms, you can only feel that if you're alive.
Yes.
So
That's true.
I think, though, perhaps what they're getting at is things like, I think we've all emphasized symptoms a lot and quality of life and the patient feeling better, but I was accosted and told, well, what happens when you don't have symptoms? How do you evaluate? How do you assess? And I think that's quite difficult for the patient who incidentally was discovered to have a neuroendocrine tumor and does not apparently have symptoms. And I think that's quite hard. You even can't measure metabolites. What are your objective criteria? It's quite hard to think. And I think in that situation, it may be the tumor gets so large and wherever it is that causes either compression or obstructive type problems, or in the case of insulinoma, overwhelming hypoglycemia where the patient ends up having a drip of glucose all the time, and there comes a point where they don't have it and they will die from the hypoglycemia. But I think if they don't have symptoms, it's hard. We don't know how to monitor patients. I don't know if Dr. Kocher has.
Well, from the clinical viewpoint, if they're not symptomatic, and it's always nice not to be symptomatic from tumors. If you have to have a tumor, it'd be better to not have symptoms and have symptoms. But otherwise, we keep track of the tumor size and changes over time, and to make an assessment as is this tumor about to threaten an organ function? Is it going to reach a point where it's going to start affecting the liver? Is it going to reach a point where it's going to block the bowel or something like that? So if there is an indication that there's going to be an impending organ involvement, that's a time to come in and say, we should be treating now, because if we wait and you have symptoms, it's actually going to be harder to treat at that time. But certainly find that in following a large number of patients, that we have a sizable proportion of patients that have relatively slow-growing or very stable disease, especially in octreotide, which just doesn't change from sometimes over years, and there's no indication that we would benefit that patient by treating them. I can't make them feel any better than they're already feeling. I could probably make them feel worse, and that's not our aim. But I certainly could make them feel better. So we look to see whether or not there's any other thing that's happening, that the disease is progressing, where you can predict that they're pretty soon they're going to be feeling one sort of symptom or other from that, and intervene at that point.
Well, I'd like to thank our last group of people for staying till 11:30 on a Sunday morning. Also thanks to the patients. Now, one thing here, we'd like to thank our sponsors that are all listed in the programme for having sponsored the meeting. And I'd like Maureen, who's my co-chair, to come and say the final comments. Maureen,
before you do that, Maureen, allow me to thank you and all the organizing team, Robert and so on again, for organizing this conference. I think for me personally it was really a very interesting experience, a lot of exchange. I learned a lot during these 2 days, so I'm involved with this topic since many years, but still you get new information, you get new roads, new ideas to go. And I very much hope you will repeat this experience in the future, because I think it's really a very good example how doctors, medical professionals and patients, nurses and all can work together and exchange ideas. I think this is a very good idea and you should repeat it.
May I echo that? May I echo that and say that for me it's been most educational and actually moving at times, because I've not actually presented my data to the patients. And I'm either lecturing to students, in which case I give them help, or I'm with my colleagues sparring, as you can hear, and we do that because that's the way we get the best out of each other. And hearing the patient's involvement in this has taught me a lot. I always try to tell my patients everything I know about their conditions so they're part of the decision-making process. I think this is what this conference hopefully has shown you. Did you notice how much discussion there was over certain things? So there's no one right answer. The only right answer is the answer for you. And you as an individual, your condition is different from everybody else's. And I've just learned today how important that is, that you, the patients, really have to drive this, and you are driving it, and I think you've been fantastic to actually even contemplate putting on a meeting where the profession has to face the patients. And you've all been very kind and generous, and I think we're not going home hurt and battered. But actually, on the contrary, we're uplifted. Thank you all.
Let me add that based on an incident yesterday, that for a planned future conference, that one of the things that you can include in your advertisement is that this is a conference that left Dr. Waltering speechless, and that's never happened before. So if you advertise that, you probably have an awful lot of Americans coming up trying to wonder what this is all about, because nobody's ever seen Dr. Waltering speechless before.
And he was actually asked to be controversial, and he wasn't as controversial as he usually is, so, hey, what can you do, you know?
We're so encouraged by those remarks. Thank you so much that we're coming together like this, hand in hand, you know, with our common spirit. It's really very gratifying and very encouraging, and we are going to go forward. But first, I'll tell you how we're going to go forward in a minute. But first, some thank yous. An enormous thank you to Novartis, our platinum sponsor, without whom this conference would not have happened. Absolutely could not have taken place. Thank you so much. Also, a thank you to Green Shield, which is in Canada. Some of the funds of Green Shield Canada, a health provider company, were designated to help sponsor what we call scholarships, to help people come to help people be at the conference with registrations and hotel rooms, and we're very grateful for that. We were delighted also to have a grant from Tersica. We're delighted to have a grant from Covidian, delighted to have a grant from Roche, from Interscience Institute, from MDS Nordion, from Draximage, from McKeel Marine Limited, that was through one of our patients, our group, from the Carcinoid Cancer Awareness Network in New York, from Delcaf, from Lantheus Medical Imaging, and recently, just once again, from the Carcinoid Cancer Foundation in regard to the videotaping, and individuals, Rob Baldock, Lynn Chouinard in Alberta, Bob Logan, and a number of others who have individually made donations to CNETS Canada. We had $100 in the bank this March, CNETS Canada, and we put on an international conference. So it can be done.